related problems and medical problems in pregnancy. Basically, medicine, pregnancy, like it. So one of the things that I was asked to give a talk a couple of years ago at Doncaster for the ACP conference they had there on prescribing was prescribing in pregnancy. So I thought I would kind of hash up the talk a bit, zhuzh it up, and we could go through that really. I did say it was interactive. So if you have your mobile phone on you, you should see in a second a slide pop up. If you want to log in to polev.com and enter kind of my name with 078 at the end, there'll be some interactive questions. So you don't quite have to put your hand up and say out loud. You can put your answers through there. So I'll give you a few minutes, and then when you're ready, we'll move on. Also, my cat's a bit loud today, so she may end up trying to crawl in front of me. So apologies if we get some feline fun. So I guess the first question we're going to look at is, how confident do you feel prescribing in pregnancy? And when you're ready, just pop down your response. So we've definitely had 3 people respond. If anyone's there, fantastic. Don't make me do it. Yeah, I used to think that. Fine. So that was kind of a test question, really, to make sure the kind of system's working. So, you know, and if you need the details, they're at the top. So, yeah, there's a lot of anxiety with prescribing in medicine, and I think we can figure out maybe some of the reasons why. So everyone that kind of suggested that they were a bit anxious, can you put maybe some reasons down as to why you feel anxious or concerned about prescribing in pregnancy? I don't know if this is taking some time or if we're not sure.
I'm still struggling to log in at the minute, but I'll keep trying.
Okay.
So I've chucked 3 responses in, and they're all sort of shown from my side.
Cool. All right. Maybe if I click like that. Oh, sorry, bear with me. So we've got lack of familiarity, uncertain with doses. Initially it was due to the baby. Now I understand that mama is priority. Cool. Okay. Limited information in the BNF. Absolutely. The BNF is unfortunately really biased. It basically just says do not prescribe pretty much every drug. I think even in paracetamol it does say to be cautious. So, you know, you're not going to feel very confident, are you, when you're using that as your specific, you know, where you go to when you use it for everything else. So actually, yeah, these are kind of what I'd expect, and I completely agree. When I started off like this, I think I felt similarly. So the aim of the talk today is to kind of discuss the basic principles of prescribing pregnant women, look at some of the common scenarios that you might prescribe in pregnant women, and maybe some of the drugs that you should never use in pregnant women. Okay. At any point, if you have any questions, feel free to just put your hand up, I'll answer them, put them in the comments list, and yeah, you know, make this as interactive, make this as Q&A as you like. So first of all, whenever you prescribe any drug in any person, you have to make sure the benefits outweigh the risks, and it's the same here, except the benefits need to both include the benefit to mum, the benefit to fetus, and the risk to mum and the risk to fetus. Okay, and when you think about a pregnant woman, you have to think about the stages that they go through in their pregnancy. Now, traditionally, we split this up into 3, okay, and we call them trimesters. And actually, they're quite helpful into allowing you to think about what happens in pregnancy. In the first trimester, you have all of the development from, you know, one single cell to many different cells, and then starting to get some organ structure. Then in the second trimester, you get the organ structure and the organ development. And then in the third trimester, you get fully on growth in the fetus and preparation and readiness for birth. Okay. So when assessing and treating a woman's condition, you need to think about what would you do in a non-pregnant woman, okay, rather than having to think about already assuming that a modified, reduced or suboptimal treatment's needed, because actually most of the time the treatment's very similar, if not the same. So when reviewing current medications, you need to avoid adjusting and stopping medications that already provide clinical stability when there is low risk to the fetus and a high risk to mum if you change them. So mum is always a priority in the way we look after pregnant women, but we do have to make sure we take into account the risk to the fetus as well. So antidepressant medication, there is some suggestion that there might be some risk of preterm birth, but the data is very mixed. And in actual fact, we find that nowadays, most of the time, we have no issues with antidepressant medication. And the stability that it provides mum outweighs any risk to the fetus. Warfarin, we would usually say no in pregnancy, but in prosthetic heart valves, the risk of teratogenicity, so the risk of a birth defect, is actually lower than the risk of the mum having a potentially horrific clot and thrombus of her heart valve, and essentially then death associated with that. So actually the warfarin here is really important, so we wouldn't necessarily change it for that, but you wouldn't give warfarin for a VT in pregnancy because actually the risks outweigh the benefits. And, you know, other drugs here such as tacrolimus, which is an anti-rejection drug you can use for women with renal transplants. We used to say, oh no, we can't use anything like that in pregnancy because it will attack the fetus. But in actual fact, there have been many successful pregnancies with women with tacrolimus, and actually, if they don't have it during pregnancy, they could reject their transplant and it could cause them a short life themselves. And you know, no one wants to necessarily leave their child without a parent, particularly when I say short life, the often life expectancy reduces to a couple of years. So where do you get all the information from? Because that's sometimes difficult, isn't it, to be able to make those decisions? Well, if you don't know, there are pharmacists, obstetricians, and certain physicians that will have an idea. There's a general principle that older generic drugs can tend to be safer because there's more detail on them. But this website is particularly useful, and it's the UK Tetralogy Information Service, and it's much better than the BNF, and it has most of the common drugs that you'd use. So I'd recommend that you have a look at that and have a look at the information based on your particular drug. ToxBase is also really quite good as well, and I recommend that if you're uncertain, have a read through ToxBase because it can tell you a lot that you don't necessarily realise, and there's a specific in pregnancy section in ToxBase. So I appreciate there's a lot of information here, but we'll get through some of these last principles. So when you prescribe something for a woman who's not pregnant but is of childbearing age, it's useful to think of that, you know, the use of that drug and what happens if she was to get pregnant. You know, is it okay if she's okay and gets pregnant on that drug? Would it need to be changed, or is there actually like a big no, she shouldn't be getting pregnant on this drug? And so is it worth to continue that drug or use that drug in the first place? Or, you know, is that drug really necessary and actually you do need to give it because the condition that they have is, you know, so profound that if they don't have the treatment, they'll get unwell. So it's really kind of important to have a look through that. If the latter of those three is important, then sometimes contraception and having discussion about family planning is really important as well. And that's something that we don't do very well in medicine, is pre-pregnancy counselling. Okay. And one of those things is such as things like sodium valproate, which is used in epilepsy, and particularly some types of epilepsy when they're resistant to other treatments. We would recommend a woman does not ever get pregnant on sodium valproate, because it's guaranteed to cause fetal abnormalities and distress in from the mum, from actually, you know, having a child born with significant fetal abnormality. And for example, you might realise, oh, you know, we give apixaban and rivaroxaban for DVTs, but actually they're not ideal for women if they get pregnant. So it's having that conversation that if you're starting someone on apixaban for a blood clot and they're young and female, then actually you might want to say, if you're going to get pregnant, try and plan it and see someone about it so we can change your anticoagulation as necessary. Okay. And also remember that some medication that you give impair contraception. So for example, if you're giving someone some antibiotics, maybe for a chest infection, and they're on a contraceptive pill, then actually you may find that that contraceptive pill becomes less effective. So just be aware of, if you're prescribing in young childbearing women, you know, we'd never really remember to ask about a history of contraception, but actually it is really important. Okay, so those were the general principles of pregnancy. Okay, obviously I'll make sure all these slides are available for you to read through at your own leisure as well. So we're going to talk about a case. So we've got a 32-year-old female here who was involved in an RTC and she's developed whiplash. She's 34 weeks gestation and it's her first pregnancy. She was declared medically fit, but she's still in a bit of discomfort. She's had no worrying features of trauma. She's not had any bleeding. She doesn't need any anti-D. She's fine. She's been taking some paracetamol, but she's still in quite a bit of discomfort. And she's just wondering, what other analgesia might you want to provide her with? Cool. Okay. So change to cocodamol sounds pretty reasonable to me. No one went for the ibuprofen, and there was someone that suggested another option. I'd be really interested to hear what that other option would be.
It was me.
Hi.
Hi, Snicky. From my stint at working at Jessop's, occasionally, it's just a habit that everybody's on dihydrocodeine, pregnant or pre or postnatal. So I think from that, I just get it in my head, just give it to everyone who's got a small human near them, basically.
Yeah, no, that's very very reasonable, and actually it's very, you know, it's virtually similar to codeine anyway. So and the way that it's metabolized is pretty much the same. Some people, however, are more sensitive to dihydrocodeine because of how it passes through the liver on first pass. So actually that's a really good option. So good. I'm glad no one went for the ibuprofen. Does anyone know why? Anyone want to hazard a guess?
does it prevent closure of one of the vessels in the heart if it's at a certain stage, or I might just be making that up?
You're not making it up, John, and that is sort of the right answer. So ibuprofen is a prostaglandin inhibitor, okay, and you need your prostaglandins to remain some of your vessels to be nice and open and relaxed. Now, unfortunately, part of the cardiac circulation of the fetus is that it doesn't actually pump blood around the lungs. So it has to bypass this by something called a foramen ovale, which is a little bit of tissue way big that's a vessel, and it basically pumps blood from the right ventricle into the left ventricle, and it connects basically the pulmonary artery to the aorta, so it bypasses that aspect. The problem is ibuprofen at about the time of 32 weeks plus is at risk of closing that because it becomes prostaglandin dependent. And interestingly, when you give birth, not me personally, but when women give birth, the stress response of being birthed and breathing for the first time actually inhibits your prostaglandins and closes that foramen ovale, allowing you to breathe and push blood through the lungs, the water out and getting air in. So that's why we don't give ibuprofen at that gestation. So yes, if the woman really needed the pain relief, which sounds like she may well do, I think both of those answers of dihydrocodeine and codeine are definitely worth giving a go. Fantastic. So paracetamol is safe in pregnancy. Obviously, I would ask that we stick to the dosing that you'd have in the BNF. I wouldn't overdose, and actually, interestingly, overdose of paracetamol in pregnancy is managed the same as it is in non-pregnancy. However, most places are using the SNAP protocol, but the SNAP protocol wasn't tested in pregnancy. So we probably state that actually we'd stick to the old-fashioned method of 3 bags over 21 hours. We've already talked about NSAIDs. Intermittent doses in the first and second trimester seem to be fine, but prolonged courses or in the third trimester aren't. The only thing that we would say with opiates is that towards the last week or so of gestation, we might want to avoid them because the baby, when born, might have some withdrawal symptoms. So it's just being aware of that. And then there's no real data about nefapam, and unfortunately for a lot of women that may have neuropathic pain, things like pregabalin and gabapentin, they've got a lot of mixed safety data and we don't really know their safety. We think they're probably okay in the second trimester, but we're not sure with the discussions about reduced birth weights in the third trimester, whether they're really that safe. Okay, so that was kind of a whistle-stop tour around pain relief. Now we're moving on to maybe something that's a bit more acute. So we have a 24-year-old female, and she's in a second pregnancy and she's 28 weeks gestation and she's an asthmatic. She attends with shortness of breath, cough, fever and wheeze. And you diagnose with this lady acute severe asthma. Okay, so which of the following treatments would be safe to give? Okay, fantastic. Well, I'm really glad that everyone has identified that nebulizers, amoxicillin and prednisolone are safe to give, and I think, you know, absolutely fine. And I'm glad that you've kind of picked up that and realizing that pregnant women do need pretty much the same treatment as non-pregnant women. Hydrocortisone is actually fine as well. And magnesium sulfate is fine in pregnancy. We use magnesium sulfate for a multitude of different things. In fact, we use it for preeclampsia and the treatment of that and really bad blood pressure. But we also use it in women who are likely to have a preterm birth, and it was called the Precept trial, and it's one of the most amazing trials in pregnancy medicine. It reduces cerebral palsy by a significant amount, with numbers needed to treat as low as 3, which is really good for any kind of intervention. Excuse me. So actually in severe asthma, it's absolutely fine to give those medications as well. And aminophylline, it's probably not a drug that many of you guys have actually used before, but can be used fine in pregnancy. You just have to check the levels and just be aware that the levels might be artificially low in pregnancy because pregnant women have a very high hemodynamic state where the kidneys work really, really well, and they actually metabolize out the aminophylline probably quicker than a lot of other people. Good, however, that no one's suggested doxycycline, and that's actually for the fetus more than anything else. And unfortunately, if a woman takes doxycycline, it can stop enamel forming on the fetus's teeth, and they can end up with dentine teeth, which are bright yellow. So we wouldn't recommend any kind of those antibiotics given. So yeah, this kind of goes through what we've already suggested here, that acute severe exacerbations of asthma should be managed as we would normally manage them as an emergency in hospital. And actually they should be treated even more vigorously compared to non-pregnant women, because actually the complications of a severe asthma attack in pregnancy, although they are perhaps slightly less common than the non-pregnant population, you don't want to end up intubating a pregnant woman. There's a lot of complications associated with it and with asthma. So you want to basically hit them with everything that you have very quickly. And the steroids are fine in pregnancy. You probably know that we use dexamethasone to help with fetal maturation of the lungs in prematurity. And that's because the dexamethasone crosses the placenta and helps to mature the fetal lungs. But prednisolone and hydrocortisone don't really cross the placenta because it's metabolized there anyway. So actually we can, and in fact in COVID we were using prednisolone rather than dexamethasone for the treatment in hypoxic pregnant women. And then obviously with antibiotics, we know that pregnancy causes you to change your physical appearance and your anatomy sometimes changes, and so for things like urinary tract infections it makes you more susceptible to that. There's also a slightly general decrease in your immunity, and so often you can be more susceptible to different types of bugs, so that's something to be bearing in mind. If a woman comes in with meningitis and they're pregnant, then you should cover them for listeria because they're more likely to not have the defences to keep it at bay. Women will often need longer courses of antibiotic, so just check the literature and the guidelines. There are guidelines for UTI in pregnancy as per NICE and per SIGN. So for example, in UTIs they actually need 7 days of treatment rather than 3. And there are some antibiotics just to be careful of. So trimethoprim, as you can imagine, is a folate antagonist. So and we know that we need folate for the division of cells, and therefore we wouldn't give it in pregnancy, because if you are inhibiting the folate, you're inhibiting the ability of the fetus in the first trimester to produce all of the things it needs to create successful organs. So we'd avoid it in the first trimester, and you probably would only really use it in the third. And then nitrofurantoin you wouldn't use in the third trimester because it can just affect problems with the bowel and cause problems with bowel health in general. As we said, we would avoid tetracyclines, so doxycycline in pregnancy, and it's really important that you try and obtain microsamples for these infections so that you know what you're treating and can get the best antibiotic for that. Obviously that's good antibiotic stewardship, but sometimes with pregnant women you actually need to have a test of cure, and UTI is one of those. And as you're well aware, sepsis, you would treat it aggressively. I can see a few bits in the chat. I'm really sorry. The Poll EV app, I'm sorry that it's causing a bit of trouble. Just if you can keep going with it, it'd be grand. If not, if you just want to put your responses in the chat, I'll be absolutely happy with that. Has anyone got any questions so far on asthma or pain relief in pregnancy? No. Okay. So we're going to move on to a slightly more hair-raising case. Okay, we've got a 38-year-old woman. Okay, this is actually a patient that I saw, apart from this strip, which is not, I just took it out of the internet, but she was 30 weeks in her third pregnancy, and she came in with palpitations, breathlessness, and a bit dizzy. She had a heart rate of about 200, a slightly low blood pressure, and saturations of 98% on air. I'm so sorry, come on. Ugh. So you see this ECG and you think, oh crap, what treatments are okay to start? Okay. Let's just see if that's, oh, okay, that might be refreshing now. Good, so vagal maneuvers seems to be the favourite. Bisoprolol is someone's choice, okay, interesting. Lovely, okay. So anyone that suggested vagal maneuvers, does anyone want to talk to me about what they are? What do we mean by vagal maneuvers?
Getting somebody to sort of blow into the a syringe, you know, to try and create pressure in your body. Yes, I'm sorry, horrible explanation.
No,
yeah.
I mean, often just describing exactly what happens is really important. Yes, so definitely trying to blow into a syringe, it helps to try and give you that Valsalva maneuver, doesn't it? One interesting thing to do though is when you're getting them to blow into a syringe is being able to get their legs up, because actually if you increase their venous return, it's more likely to give them a higher vagal stimulus. Okay, so actually I would, if you're going to do that, definitely blow in that syringe and get their legs up, because it's actually been shown to be a lot more effective. Can be a bit more challenging trying to get a pregnant woman moving around the bed, but hopefully you'll be all right. Carotid massage never really works for me. It never really sustains for very long, so I never tend to do that. And I just wonder, who suggested the bisoprolol?
Me.
What's your thought process, John?
I was thinking, well, I was going through thinking about safety, and I presume that vagal maneuvers, if we were thinking an SVT, would be the first line to go in, and DC cardioversion if they were hemodynamically unstable. I'm not sure about adenosine, flecainide, or amiodarone as antiarrhythmics, and I just sort of presume that bisoprolol was safe and suggested it as an option. I am fully aware that I might be wrong on that one.
No, that's absolutely fine, and it's interesting to think about that. And beta blockers are safe-ish in pregnancy, and we'd use them if we needed to. But it wouldn't be my first line of choice. If we just go back for a moment and have a look at this lady, her blood pressure, yeah, it's probably fine. Heart rate's 200. She's feeling dizziness, short of breath, nausea. So I think it's very reasonable to go ahead with vagal maneuvers. But if they don't work, it's actually you just follow the ALS guidance, which is go ahead and give adenosine. Now this caused many a fright to some of the ED colleagues that I worked with in Doncaster about 4 months ago when I was when I was locuming there, and I was like, no, I know what I'm doing. I've done it before. And yeah, unfortunately, everyone feels absolutely shite on adenosine. It makes you feel like you're about to die. But it worked. Nice big slug of it with a massive flush. It works. And actually, interestingly, adenosine will barely make it to the heart, let alone make it to the placenta. And that's because it has a half-life of about 6 seconds. So this is why you need to give it with a massive flush. And what it does is it just turns off the heart and turns it on, essentially. And by the time that it gets to the placenta, there's actually no active drug left. So we're quite happy that adenosine is safe. DC cardioversion is also safe in pregnancy. We just ask that you may have some fetal monitoring. So if someone's really unstable, then go ahead without. But if you've got time to get fetal monitoring, then use it. So just to be aware of that. You can use flecainide in the acute setting. I'd be less keen on that. I'd probably go straight from adenosine to cardioversion if that didn't work. And you can use beta blockers if you're kind of running out of options. Bisoprolol is okay as an oral agent. Probably might want to consider an intravenous agent at this time, but it can affect the fetus a little bit. But predominantly it can cause hypoglycemia towards the end of the fetus's gestation. So if you're around the 36 to 40 week mark and you're potentially going into preterm labour or labour, when that baby's born, they'll need to have close monitoring, not only for their heart rate, but also for their glucose level. Beta blockers have also been found to have a slight reduction in birth weights as well, and can cause some growth retardation. So we don't tend to use it first line, although we consider it safe for most other things. So it's just to bear that in mind. We use them if we need them, but not first line. And amiodarone you can use in pregnancy, but you have to be aware of the fetal thyroid, and the fetus will need a checkup. Probably 6 weeks. At their 6-week check, we'll need a thyroid check, and that should go the same with any pregnant woman having any iodine contrast as well. So if you're going to have a woman that has a CTPA, they need to be told to make sure that their kid is checked at 6 weeks to check their thyroid, just to make sure there's no complications. Okay, is that helpful, John?
Yes, very much. Thank you.
Lovely. All right. And this is pretty much where what we've explained it already. Nausea in pregnancy, so probably something that you'll get involved with quite a bit. And there's quite a bit of controversy at the minute about ondansetron, and I'll get to that shortly. Most antiemetics, however, are safe in pregnancy, and predominantly we use cyclizine, although I don't think it works, and prochlorperazine first line. And prochlorperazine has a particularly good safety data to it, but with prochlorperazine, you might just want to do an ECG and just make sure their QTc is fine prior to giving them any, which a lot of obstetricians and GPs forget. In pregnant with recurrent vomiting, and therefore probably either have hyperemesis or something else going on, if they have poor oral intake, you need to put them at risk of Wernicke's encephalopathy, or consider them at risk of Wernicke's encephalopathy, and that's because they have a high metabolic demand and not just getting enough in. So make sure that you give them either thiamine or Prabranex before giving them anything like glucose. These women are at risk as well of metabolic acidosis from kind of starvation ketosis. So it's just be wary of that, and if you're going to give them some glucose, just make sure they've got some of that fancy yellow stuff going in through their veins first. Also, unfortunately, pregnant women, if they actually attend hospital, they're at increased risk of having a VTE by something in the region of 2 to 8-fold. So don't forget your prophylaxis with pregnant women, both stockings and dalteparin, please. Okay, and if women have got acid refluxy symptoms, then ranitidine and Gaviscon are better first line. PPIs can be used, but ranitidine or famotidine, or whatever you're going to call it these days, tend to be better because there's more data on them to say they're fine. So there's a lot of protocols at the minute looking at replacing ondansetron as a first-line antiemetic. So if we look at the data that's come out back in 2019, 2020, there was a suggestion that it increases cleft palate deformities by a very tiny amount, and that's from 0.13% to 0.15%, which is equivalent to 1 in 20,000 pregnancies. What does this mean? Well, it's not significant. I think ondansetron has a much better side effect profile than most of these other drugs. Some of these drugs also cause like cardiac toxicity and instabilities, and I don't think cyclizine works anyway. So in actual fact, I would consider ondansetron safe still, and I would still use it, particularly if things like prochlorperazine can't be used, or they're not tolerated particularly well because of like other symptoms like dizziness. So I would go ahead and use that. And if you look at the UK TIS data, the nomograph there, then it will talk a little bit about that and can provide you with further details if you're interested. And also hyperemesis, particularly in a lot of vomiting in pregnant women, causes more harm to fetus and mum than the actual risk of the medication itself. So controlling that's really important. This isn't like another thalidomide where, you know, I think 1 in 3 people got serious malformations. This is 1 in 20,000 where the risk of fetal growth restriction is actually really high in women that have protracted hyperemesis and problems with hydration at that point. Again, it's about balancing the risks of giving something versus the risks of not giving something. We talked about VT in pregnancy. We know that it occurs more often. Admission alone increases the risk of VT by 4 times, and that, you know, all women should receive prophylaxis in hospital, and those at risk outside of hospital should do as well. If a woman is diagnosed with a blood clot, whether it's a PE or a DVT, they need to be having at least 6 months of treatment and up to or beyond 6 weeks postpartum. And it doesn't matter if you go above 6 months to deliver that up to 6 weeks postpartum treatment. It's really important because unfortunately, the most common time for a pregnant woman to have another blood clot or a blood clot in general is between birth and 6 weeks postpartum. Use the current weight for treatment, not the booking weight. A lot of times we were talking about using the booking weight, and that's wrong. So use the current weight, okay? And we are so used to now using apixaban, dabigatran, rivaroxaban for VTEs. In pregnant women, don't use them. They cross the placenta. We don't know the specific outcomes, but we think there is significant evidence of teratogenicity. So just don't use them. And if you've got a woman of childbearing age, have a serious discussion with her about the risk of, if they get pregnant, they need to be switched. Okay. And that will be to low molecular weight heparin of whatever choice you're using, whatever trust you're using. I'd actually just added this slide today because I was quite interested in mental health, because it's becoming a hot topic. So mental health problems in pregnancy are the first cause of deaths for new mothers up to a year postpartum, and a 5th cause of death for pregnant women in general. And unfortunately, a lot of pregnant women have their medications stopped when pregnancy is discovered. And the lack of that understanding about the medications is actually what's probably responsible for some of these women's deaths. And if you read things like the Embrace reports, which are a confidential inquiry into the death of each pregnant woman that happens up to a year postpartum, there are some really sad stories about women being denied medication because a practitioner thought it was unsafe and didn't actually seek help and advice. So most SSRIs are safe in pregnancy, and particularly if they're on one, keep them on it if they're stable. tricyclics have mixed data suggesting safety. So I would be cautious, and even I would probably be discussing with whoever started it as to why they were on it, and what should we do about it. Anti-epileptics and pregabalin for mental health stuff should try and be avoided where possible, and there should be discussions again with the primary prescriber as to how those should be changed to support pregnancy, and particularly if they're used in mental health. And then finally, antipsychotics. They generally all seem about safe, but we think that the newer, more targeted ones tend to be safer than the older ones that are much more general, and I consider them much more dirty, such as like haloperidol and like piothentone and stuff like that. So we tend to go down the role of looking at trying to get women onto newer antipsychotics if they were going to get pregnant. As always, consider the benefits and the risks of stopping it, and if in doubt, speak to a specialist. So we're kind of on the last couple of slides, you'll be thankful to hear, and we can see here that there are some drugs that were really contraindicated in pregnancy, and they're all on the left hand side. And you might think ACE inhibitors might not be so bad, but actually they can cause the kidneys not to develop in the neonate. And there's an asterisk here against statins, because I recently found that you can use rosuvastatin in some women if it's really necessary, but rosuvastatin is out of all of the statins, doesn't work the best but has the least side effect profile. And then we've got some drugs here that are problematic or contraindicated, and you can see here that actually we've got some biological therapies now that are being used in pregnancy, such as vedolizumab and rituximab for things like IBD control, and actually even in severe COVID we've been using vedolizumab in pregnant women with successful results. There is some new guidance out there from the Rheumatology Royal College, and the institutions that produce guidelines about how to use them in their medical problems, and also from gastroenterology. Quite often, provided that you don't give a dose beyond about 33 weeks gestation, and they're not too long acting, then actually it often has the best effect for your women with kind of autoimmune conditions. And so that's kind of been revolutionary, really, because we've had some women with like really intolerant and insufferable things such as like lupus or rheumatoid arthritis, or some really bad IBD that we traditionally say, oh, autoimmune diseases get better in pregnancy because the immunity lowers, but in some women that's just not the case. Okay. Yes, and my cat agrees. So finally, I just like to kind of point you to this slide as to how to approach prescribing in women, particularly when you're considering either new medication or you're just not sure. So does a condition actually require treatment? Should the treatment be different to that of a non-pregnant woman? And does it benefit mum more than the potential harms to the fetus? Have you discussed it with mum? Does there need to be a dose adjustment, or a course change? And don't forget to think about pre-pregnancy counselling and prescribing changes. Okay. Well, thank you very much. Really sorry to bombard you with a lot of information there, but I'd love to take any questions or any thoughts or bits that you want to discuss. Everyone's as quiet as anything. Has anyone had any scary problems, or does anyone want to share any times that they felt really doubtful, or had any issues before?
I think, like I said, I did shifts at Jessop's as a nurse, not as a AMP, and it's really nice that you're here and interested in this, because obstetricians are obviously amazing at what they do, midwives are phenomenal, especially in Sheffield. But when you have somebody with severe asthma, I looked after a girl with severe asthma who's been nursed on an obstetric unit. You know, it's not their speciality, so it's just really nice to know that somebody like you as a contact to help out in situations like this, because it's a very, very grey area, and these ladies seem to, especially if they're quite far on, seem to end up at Jessop's, and perhaps they shouldn't be at all. They should be in I don't know what the answer is. I don't know, but it's great. It's great. It's great that somebody's interested in this, because I think it's an amazing topic too.
Yeah, I mean, I could discuss this all day in terms of, for example, how, you know, pregnant women presenting with a problem should be managed on that problem, not just because they're pregnant. So there's a lot of idea in medicine that we should just be sending women to Jessop's all because they're pregnant, but actually they're not getting the specialist care that they need. There's a lot to do. Physicians are really worried about pregnancy, and they need some further education in that. And really interestingly, NHS England are setting up something called maternal medicine networks, and I'm currently involved in the work to set up South Yorkshire's maternal medicine network, and hopefully we'll have a job as a consultant in the next couple of years as South Yorkshire's obstetric physician. So I will no doubt be involved in a lot of cases like that, and it's a good thing.
Yeah, definitely. Thank you.
And Jade has written about, she had no idea about TFTs for fetus following CTPA, have been involved in many patients who have had it, but did not know that. Yeah, we don't, we forget to mention it. Most of the time it's absolutely fine, because most of the iron is metabolized by the fetus themselves, and they can cope with it. But you know, it can be we don't really, no single one trial has occurred to see exactly what this is going on, and maybe it might be a research project for me in the future. But we just advise them to just get a check, but we just forget to tell them to do that, and it should just happen at the 6-week check. Lovely. Any other questions, or is everyone ready for their dinner?
I thought that mental health statistic was crazy. I didn't realise, obviously, like suicide, and you say it's the biggest cause of death after childbirth. It's just awful. Yeah,
it's really downtrodden as well to hear that. We've had some horrific cases. I always say Doncaster, but it's because I've done a lot of my work at Doncaster and Bassetlaw, a lot of my training there, and so often get involved in maternal stuff there as well. And you know, I know all about the maternal deaths that have occurred at Donny, and some of them have been like, you know, woman found hung herself at home, and you're just there like, oh crikey. And then you look at to why that happened, and often there's a systematic failure and things have been missed, as opposed to actually someone just unfortunately having a simple mental health disorder. And we're working really hard. It's not just about medication, it's about the right services, and there's currently being perinatal mental health services set up across South Yorkshire, particularly by Ardash, and that's something that I've been passionately helping out with as well.
that was really helpful. Thank you.
You're welcome.
I think most of us are absolutely terrified. That's why we don't have any questions. We're like, oh, right, thanks. That's like our first insight, really. I don't know about anybody else, but I think prior to that, I probably would have avoided like reviewing a pregnant woman, just because we're completely out of our depth, or I would feel like that anyway. So it's really good. Thanks, Rob.
Yeah, learnt loads. Thank you.
Lovely. Well, we'll call it to a close then. I really appreciate everyone spending time out of their busy days to, you know, listen to me drivel on a bit. Next week is next Wednesday, I think, at 6, and it's going to be on acute medicine emergencies. So kind of 4 things that would come up on the AMU, and we'll talk a little bit about how you might manage them, and I'll give you the answers. All right, and then The week after will be on delirium in the young patient, and then 2 weeks after that, because I'm on an annual leave, I'd like you to bring some cases, and we'll do some kind of CBD discussions, and we can maybe even do some portfolio stuff at the end of it with those discussions. So if you've got a really interesting case that you want to bring, maybe some lessons learned that you want to share, obviously make it confidential if we're recording it, okay? Then we could kind of do that and use it as a bit of kind of a teaching and learning opportunity for everyone. All right, fantastic. Take care, everybody.
Thank you very much. Thank you.
Thanks so much. Bye-bye.
Bye.
Thank you. Thank you.